You're listening to
CRST
podcast
from Bryn Mawr Communications.
Hello, and welcome to this episode of International Perspectives on Dry Eye Disease. I'm your host, Laura Perryman. In this series, clinicians from around the world are going to comment on some of the under-discussed, underappreciated aspects of dry eye disease that are sometimes glossed over. In this episode, we'll be reviewing which underlying ocular conditions clinicians should consider when evaluating a patient during a dry eye consultation. In our first episode, we reviewed which underlying systemic conditions were most relevant to dry eye. And in a forthcoming episode, we'll discuss the patient journey and experience. If you missed our first episode, go back in your podcast feed when this episode is finished and check it out. But don't worry, this episode will make plenty of sense if you didn't listen to the first one. And now for our wonderful panelists. I'm delighted to introduce you to Chris Starr, who is an associate professor of ophthalmology at Weill Cornell Medicine in New York. Dr. Starr, thanks so much for joining us.
Laura, thank you so much for having me. I'm delighted to be here.
And also, I am so delighted to have Professor Fiona Stapleton. She practices at the University of New South Wales in Australia. Professor Stapleton, thanks so much for coming on the show.
Thanks, Laura. Thanks for the invitation. And I'm so looking forward to working with you and Chris.
I was really struck by Chris Starr's paper. You published it, 4 or 5 years ago, I think, looking at osmolarity amongst dry symptom patients. And I think this is a useful thing in helping us really look for and think about ocular comorbidities that we encounter in our dry eye patients. Tell us a little bit more about what you found.
Yeah, I think I agree with you. I think one of the big frustrations in this area for patients and doctors alike over the years has been this kind of disconnect between symptoms and signs and diagnostic tests and so on and so forth. And so I was trying to look at the utility of a very commonly used test, which is the osmolarity test, which many doctors use and ocular surface specialists use pretty routinely. And so what I wanted to figure out was, well, in a patient who has a symptom that sounds very much like dry eye and in a lot of places would be called dry eye and treated as dry eye, and the patient may or may not get better on that treatment. And so I wanted to know if a patient has those symptoms, but their osmolarity test, which I think is a great dry eye test, very, very much a dry eye specific test, well, what do those patients have that's causing these symptoms if it's not dry eye disease? Now, of course, that's a black and white kind of a thing for the study. Yes, you can have a normal osmolarity and still have dry eye in some cases, but, in general, normal osmolarity and symptoms that sound like dry eye, what were the alternate diagnoses that we came up with? These sort of non-dry eye ocular surface disease subtypes is what I call them. It's a long name. Some people say masqueraders, some comorbidities, co-conspirators, and again,
Mischief makers.
Yeah, that's the topic for another whole podcast. What do we call all these things, and can we all get on the same page? But in a nutshell, the in this study, there were a number of common diagnoses that were not typical dry eye disease that were, attributed to the symptoms. Things like conjunctiva chalasis, floppy eyelid syndrome, allergy, of course, is a big one. Anterior blepharitis in some cases. Things like pinguecula pterygia. EBMD, a big one, very commonly missed. And if you're not lifting that upper lid and looking at the superior cornea, you're probably missing that a lot. And then more rare ones, SLK and various things like that. But those were the big ones. And then, which wasn't in that study, but would be the logical follow-up would be if you add in an MMP9 diagnostic test and you look at those combinations of osmolarity, MMP9, and symptoms, well, the pluses and minuses and the combinations there, I think, get very interesting very fast. And so that would maybe, in a year or two, if and when I publish that, we'll come back and discuss that.
As far as, I love how you're thinking about this, of like, the osmolarity as being a way of looking at the entire lacrimal functional unit, the health of it. Are you in a compensatory phase with MGD rosacea? If there's a heavy MMP9 load and normal osmolarity, is it the compensatory phase? Is there a significant amount of Demodex present, which is so easy to identify just by having the patient look down? I'm impressed that recent reports of 50 to 60% of our MGD patients have evidence of collarettes on the lashes. But you'll miss it unless you're actually looking down. Ask them to look down. It takes a nanosecond on an exam. Dr. Stapleton, I'm curious about the nomenclature when we're talking about ocular surface disease. Like, what do you like to use and why? Do you call it meibomian gland dysfunction, ocular surface disease, chronic dry eye disease, dysfunctional tear syndrome? Like, what do you like to call it and why? Do you think it matters?
I think I like the term ocular surface disease because I think that's kind of all encompassing. And, the subsequent inflammation can be anywhere on the ocular surface. So I think that helps sometimes the patients understand when you're giving them something that, say, treats their lids. If you've talked about the ocular surface involving all of these structures, I think that's an easier message for patients to take home. So I would tend to use ocular surface disease, but I'd use MGD as a sort of fairly specific term as required. So I think that would capture most of the interactions I would have with patients with these diseases.
I agree with that too. I mean, OSD I think is a much better term. In almost zero patients do they have one subtype of ocular surface disease. If you're doing a good exam, which we all are, and hopefully educational things like this will get other people to do it as well, but you're always going to find multiple subtypes of OSD. Dry eye MGD is a big one, of course, but that's just one of many that you're going to potentially find if you look and do a complete ocular surface exam and the diagnostic tests and take a good detailed history, which sometimes can take a while. These patients take a while, but if you do it right, you're going to find multiple subtypes on everybody. And then, of course, you have to, streamline your treatment to kind of address all of those things, and that can add up fast.
Yeah. And there's a spectrum, right? I mean, I think we're getting better at catching people earlier in their disease state. Like, I love it when a soft contact lens intolerant patient comes in. To me, that's like early in the stage. It's like, oh, golden opportunity to keep this ship from crashing into the rocks later down the road. Professor Stapleton, do you have anything to add about the contact lens piece?
Yeah, I mean, I think the whole contact lens discomfort. I mean, Chris, you spoke about the sort of symptoms often being a bit non-specific, and I think in our contact lens wearing population, that's a huge issue. There are not that many ways the eyes can feel uncomfortable. So all of those things, whether it's contact lens discomfort, whether it's contact lens induced dry eye, so the dry eye symptoms disappear when the lens comes out, or whether there are other factors, whether it's CLPC or whether you've got lens related factors that are triggering ocular surface drying. So I do think that it is very satisfying in contact lens wearers because you obviously look very closely for MGD, knowing that they'll get meibomian gland disease about 5 years earlier than somebody without contact lens wear. So we know they're kind of a bit on the edge, and being able to pick that up and initiate treatment in a timely fashion, I think is a really positive thing that we can do for our contact lens wearing patients.
And if you're a laser vision correction surgeon like I am, and the patient comes to you for LASIK or PRK or SMILE because they're having contact lens intolerance, well, don't just jump into a surgery without addressing the ocular surface issues that are causing the contact lens intolerance, because you're probably going to make it worse if you don't address it, prior to surgery, obviously.
I agree. You wouldn't cook in a messy kitchen. Why would you cut in an inflamed surface, right? It's and those are associated with problems with outcomes and accuracy and the development of neuropathic pain that we'll talk about in our next section. All right, we're going to take a quick break, and when we get back, we'll look at how these factors might affect patient treatment. Welcome back to the show. I'd like to discuss how ocular history and ocular comorbidities affect treatment strategies for dry eye disease. We talked a little bit in the last section about inflammation and osmolarity and its role as diagnostic tools and tracking progress to therapy. And we talked about it in the preoperative patient, the contact lens patient. But now I want to segue into how that variety of risk factors might be implicated in some of these really challenging ocular surface conditions, such as neurotrophic and neuropathic disease. Professor Stapleton, can you give us some pearls on how you distinguish neurotrophic versus neuropathic disease in our patients?
Sure, Laura, thank you. So I guess in terms of conditions which really interrupt the nerve supply to the ocular surface, some of those conditions might include things like ocular surgery. It might include long-term contact lens wear, things like long-term Roaccutane use, exposure to UV or other radiation. And quite often, I think what we see is initial damage to the nerves on the ocular surface, which we would characterize as kind of nociceptive type pain, where we've got damage to the receptors on the ocular surface. Now, in some ways, that's easy to diagnose with something like an anesthetic test. So topical anesthesia will quieten those ocular surface nociceptors and the pain level will reduce. Neuropathic pain is really resulting from a lesion sort of further back in the sensory system. So more peripheral or central processing, and that's not amenable to an anesthetic test. So the pain will persist with installation of an anesthetic. So that kind of gives some idea of the degree of neural damage to the ocular surface. So in terms of making that diagnosis, it's also possible to use things like confocal microscopy and look for nerve abnormalities. This might be things like microneuromas. It might be abnormal nerve width or density. It might be neurogenic inflammation, where we have white blood cells recruited adjacent to the corneal nerves, indicating that we've got a neural response which needs at least some anti-inflammatory treatment at that point. So by understanding those differences, it perhaps helps a little bit more in terms of understanding those treatment pathways that will be required.
Yeah, and I would even, just to truly simplify it to the most basic, for the general practitioner out there who sees these patients every day, this pain without stain, think neuropathic, stain without pain, think neurotrophic. And these are combinations of things that everybody does. You take a history and you put in dye, of some sort, fluorescein, lissamine, rose bengal. You're going to encounter these disconnected symptoms and signs, and that's a very rough but very useful rubric to kind of go at these patients and start thinking about the nerves, which is something, 10 years ago, very few people did. And it's becoming more and more common now as we learn more about these things, but it's so fascinating.
And does the overlay with ocular surgical history give you any tip-offs or clues as to what the patient presentation is more likely to be?
Yeah, I think that surgery, whether it's ocular surgery, especially corneal surgery, but any ocular surgery can have an impact on the corneal nerves, at least for a period of time afterwards. But of course, cataract and refractive are the big ones that we think about, especially cataract surgery with a limbal relaxing incision. Let's not forget that, we still do those. Not everybody gets toric IOLs. And LRIs are often done with femtosecond lasers these days, and those can have a very significant impact on corneal sensation. And it's probably too deep for this podcast, but these surgical things like those incisions can either cause neurotrophic or neuropathic, and in some patients both on a spectrum. So it gets very complicated, which is why you have to have your antennae up, as it were, to be thinking about these things. But the other thing, barring the ophthalmic surgery, you got to also be asking about neurological surgeries. Patients, who have had, acoustic neuromas removed, or who, have other neurological conditions that we might not normally ask in an ophthalmic history. Things like shingles and tumors and radiation for things, brain, and then things like fibromyalgia and small fiber neuropathies and things like that. If you ask and they're positive on the history, well, that might start leading you down various neurotrophic or neuropathic pathways. But you have to ask, and again, it comes back to this detective work that we talked about before, but you have to ask these questions and do a good history, and that's going to help you in every single encounter.
That's amazing overview of the whole thing. And one thing that I've discovered recently is I need to ask about history of head trauma, concussions. Like there's even overlays of that in some of these folks.
Totally.
Yeah, super interesting stuff. And you know what I love about how as a community we're learning neurotrophic, neuropathic, we're able to, share best practices with each other, but also there's treatment options, right? So this is where it becomes interesting, and why we're so excited to share with our colleagues is, what we're learning, what we still have to go, and like what's available. I find neural stimulation to be really interesting. And so many times that the corneal nerve subbasal plexus has been disrupted, chronic inflammation, maybe diabetes, maybe contact lens overwear, maybe refractive surgery, whatever it is. And the rheostat's been ripped off the wall, right? There's no control of the quality of the tear film, but you can bypass it with some of these neural stimulation modalities. Have you come across any situations where you treated a neurotrophic situation and the patient ended up reporting more pain?
Yes, I have seen that, and usually it's if you're treating them with something, let's say oxervate, where you're sort of trying to reestablish a healthy nerve plexus, corneal nerves. Well, as those nerves regenerate and get sort of healthy and normal again, they do start to sense insults, and dry eyes and ocular surface disease. And patients who were completely neurotrophic prior to treatment didn't feel anything. That's the pain, stain without pain. As these nerves start regenerating, they start feeling things. And that's, to me, it's a good sign, even though the patient's not thrilled about it. But at least you can reassure them, hey, this is working, your nerves are coming back, and your ocular surface milieu will be in homeostasis and healthy again, thanks to these nerves that you're now feeling.
I love that. I tell my patients that, and this is something I borrowed from our mutual friend, Daryl White in Ohio. It's like, you got to climb the hill of sorrow before you can get to Happy Valley.
That's great.
I think it's encouraging to think that there is a happy valley. I think that's a lovely
Yes, I think there is hope for a happy valley. What are some of your favorite tricks for helping coach that patient through the tough times and the what they can look forward to?
I think it's about understanding that they will have flares and they will have good days and bad days. And the aim of treatment is to perhaps to increase the number of good days and reduce the number of bad days.
I love that. And it's important to ask patients that question, because sometimes they'll come back and say, oh, I don't feel any better. It's like, well, tell me more about that. And if you really ask them things like, well, how many days or how much are you using tears now? Or how many days did you have to avoid screen use? You'll find that is actually getting better. And, pain is like an important protective mechanism, right? It can be dysfunctional, but Mother Nature makes us forget pain. Otherwise, you would never give birth more than one time.
That's so true. And I think you're exactly right with asking those questions. If we just rely on, say, the OSDI, for example, the numbers can be exactly the same, but the whole, I don't use my drops so much, or I can watch TV for longer, or I can go to work. Those kind of quality of life related issues are really important to find the specific things that are important to that patient and really quiz those. So I think that's a great point.
I love that. And it's interesting to me that when you really get granular about those little micro improvements, if you have enough inches, you eventually get a mile, and you celebrate those as part of the recovery. But I find as a clinician that if I'm not even getting those micro improvements, I need to figure out what I missed.
Yeah, it's those patients where you really have to start thinking, if you hadn't thought about the nerves before, now that's a good time. When you start scratching your head after 2 or 3 visits, boy, is it neurotrophic, is it neuropathic, or something in between? But you got to start thinking about those nerves. and then asking the appropriate questions and doing the appropriate tests at the next visit. Check corneal sensation. If you have a confocal, use it. Ask the symptoms that's suggestive of neuropathic and neurotrophic. And then also the history, like maybe dive deeper into that history next time. Look at those medications, look at the history, ask him about the neurological history and things like that. But that's when those questions, at least in my mind, and I'm guilty as anyone of kind of missing these types of diagnoses for quite embarrassingly quite some time, that I should have probably picked it up much sooner, but, went down the wrong path, the dry eye ocular surface MGD path, where they really had a problem with their nerves.
So I think as we look back at all this great stuff we've talked about, ocular comorbidities in the ocular surface disease patient is multifactorial squared. There's like a lot going on here. And the nerves are this really interesting frontier to explore in our post-surgical, past medical history type patients that I think, need special consideration, special extra attention. And I know the clinical trials pipeline is robust with new tools for us to help these amazing patients. I can't thank you both enough for being here. I really want to thank Dr. Starr and Professor Stapleton for coming on the show. And I want to thank the listeners for joining us as well. If you missed episode 1, go back in your podcast feed to catch up. And if you liked what you heard, be sure that you've subscribed to the podcast so that you can catch episode 3 as soon as it drops. For now, I'm Laura Perryman, and thanks for listening.